Hey, everybody. Welcome. It's 5 o'clock Eastern. My name is Lucy McBride. Thank you so much for joining me. I'm here today with so much to say about hormone replacement therapy, women's health, and of course, the recent announcement from the FDA and HHS that the FDA soon will remove some of the warnings, the black box warnings on estrogen products. Okay, who the heck am I? I'm a primary care doctor in Washington, D.C. I do this podcast. I usually do it every Tuesday, but I've taken a little break while I've been working on my book draft and caring for patients. But my goal here is to talk directly to you. I'm not selling you any products. I'm not trying to make it sound like I know everything, that I'm certain, and I'm not going to scare you unnecessarily. I'm just going to try to help you, and have been trying to do this in my newsletter and my podcast, make sense of all the noise out there. There are a lot of medical messengers out there. There are a lot of people who are really well-intended and a lot of really smart people. And there are a lot of people who are fear-mongering and selling pseudoscience, and it's hard to know who to trust. I'm one person, um, so you can trust me, but I would recommend getting a arsenal of people you trust for various medical issues, and specifically recommend having your own personal doctor to make sense of expert guidelines and the nuances of your personal health condition. But today, what we're going to talk about, in the spirit of cutting through the noise, cutting through ideological, biased messaging, and cutting through the political entanglement with science that we often see, is we're going to talk about hormone replacement therapy. We're going to talk about something that occurs to 50% of the population. That is something that happens to every woman if she lives long enough, which is menopause. And I want to be very specific and offer you practical ways of thinking about making a decision for yourself. Because I could talk about how politics plus science equals politics. I could talk about, you know, gatekeeping on one side of the medical continuum of advice givers and then pseudoscience profiteering on the other side. I'm not going to make a lot of comments about that, although I could. I really want to help you make sense of this information that we're getting about estrogen and hormone replacement therapy to then bring back some questions to your own doctor, to maybe to yourself, when you're thinking about, should you be on hormone replacement therapy? Is it too late to be on hormone replacement therapy? What are the benefits? What are the risks? Okay, so let's dive in. First of all, let's start with some definitions. Let's start really basic. So, definitions. What is menopause? Menopause is when the ovaries, these two little glands in a woman's pelvis, no longer make consistent and robust amounts of estrogen and progesterone. That's menopause. Premenopause is the lead up to that moment when ovaries no longer make robust amounts of estrogen and progesterone. The lead up to menopause is called perimenopause. It's usually 7 to 10 years, during which a woman can have irregular periods, hot flashes, night sweats, vaginal dryness, and some of the symptoms that then accompany menopause, which again is when the ovaries are actually kind of done doing their work of making estrogen and progesterone. This phenomenon happens to 50% of the population, that is, to all women who live long enough. So it makes sense to try to understand what the ramifications are of perimenopause, the lead up to menopause, and the ramification of not having estrogen or progesterone in your body, whether that's at 51, the average age of menopause in the United States, or whether you're 81 and you've had 30 years of estrogen depletion, or 30 years without estrogen and without progesterone. By the way, I'm just going to throw this in there. The ovaries also make testosterone, but the lack of testosterone made by a woman's ovaries is actually not related to menopause. It's related to age. The ovaries stop making robust amounts of testosterone. They start dwindling in a woman's 20s and 30s. So while we tend to talk about supplemental testosterone, and I talked to Sue Dominus last week about this. She's a New York Times reporter who wrote a big splashy piece about supplemental testosterone for women. While we tend to talk about testosterone supplementation as a menopausal phenomenon, it actually is just an age-related phenomenon. And we can talk about testosterone too. But today I really want to talk about what are the implications for a woman's health when she's going through perimenopause, that 7 to 10-year window, but before she actually is in menopause? And what are the implications of menopause on cardiovascular health, bone health, genitourinary health, emotional health in that moment? And then what are the long-term ramifications of not having robust amounts of estrogen and progesterone in your body? Okay, so here's what we know about what happens when a woman is in perimenopause and losing estrogen. That is, instead of making cyclical, robust amounts of estrogen every single month and getting a menstrual period, she's having intermittent bursts of estrogen and then sometimes long stretches of time without enough estrogen. That can cause the symptoms of perimenopause. Again, hot flashes, night sweats, the sort of temperature instability, mood instability, where a woman can feel like she's PMSing more days than not, sleep interruption, and then, of course, vaginal dryness. So for some women, that 7 to 10-year period or stretch of time is really, really disruptive. For some women, that stretch of time is not noticeable at all. I'm not going to say often, but I sometimes have patients who will come in for their annual checkup with me, and they're, say, 50 years old, and I'll say, "What's going on with your menstrual cycles?" And they'll say, I haven't had a period maybe in a year," which, by the way, means they're pretty much menopausal, "and I don't have any symptoms." And that's unusual, but I do sometimes have patients who don't notice the delta in their estrogen and progesterone levels. More common, I should say, is a person who has those symptoms of hot flashes, night sweats. Okay, so what do you do to help mitigate the symptoms of perimenopause? Well, you put them on hormone replacement therapy. So you give a woman back the hormones that she's not making. By the way, the birth control pill is hormone replacement therapy. Hormone replacement therapy is the combination of estrogen and progesterone. It's basically giving you back what your ovaries are no longer making in robust, consistent amounts. So in perimenopause, when you're still able to get pregnant, like when you're in your 40s, we will treat the symptoms by giving you back that hormone with the birth control pill. The birth control pill has the added benefit of not allowing you to get pregnant. It has the contraceptive benefit. If you're perimenopausal and you're not ovulating, we don't think you're ovulating, and you're not at risk of getting pregnant, then we'll put you on hormone replacement therapy. So who should be on hormone replacement therapy and who should not be on hormone replacement therapy? This is the $1,000,000 question, and this is the question that gets one two-word answer that no one likes, especially in the public square. Who gets hormone replacement therapy? Who should be on hormone replacement therapy around the time of menopause? That is the time during which your ovaries are kind of shutting down and saying, "I'm not going to make progesterone and estrogen anymore." The two-word answer is it depends. It depends. I know, super unsatisfying, super annoying, sounds super vague, and sounds like I'm hedging. Well, anybody who says to you, let me just say this, anybody who says to you that every single woman at menopause should be on hormone replacement therapy, I would not believe that person. And anyone who says that HRT is dangerous and should not be prescribed also should not be believed. In other words, the nature of medical advice, the nature of the appraisal of medical information and data, and the nature of helping an individual patient is, at the risk of using a cliche word, nuanced. It depends. So I think I want you to be able to look for people in the medical space, in the medical messaging arena, who are able to say it depends. Because certainty, while it feels handy and convenient and nice to latch onto somebody who sounds certain, so much is uncertain. Namely, the future, right? Like, if I knew that you, my patient, were never going to get osteoporosis, never going to have a heart attack, never were going to get breast cancer, then the decision to be on hormones would be an easy one. In other words, what we have to reckon with and make peace with is that risk and the future of disease and the future of our health is unpredictable at baseline, given. So my point is, again, who should be on hormone replacement therapy? It depends. Let's talk about what the science shows. What does the data show? And this is true. What does the data show? The data show that if you take cohorts of women, we're talking about tens of thousands of women who are in the 10-year window from their last menstrual period. I'm going to say that again. If you take cohorts of women, not a single individual one, if you take large swaths of the population, tens of thousands of women, and they are all in that 10-year window since their last menstrual period, meaning they're in their 50s generally. So their last menstrual period was 10 years ago or less. And you take that group of women and you randomize them to two different treatment arms. Over here, they take hormone replacement therapy, estrogen and progesterone. And over here, they don't take hormone replacement therapy. They take nothing. These women do better. We're talking about all comers. These women do better. What do I mean do better? They do better in specific ways. They have improved bone health. They are reduced risk for osteoporosis. We know that the biggest risk factor for osteoporosis is the absence of estrogen. We know that women who take hormone replacement therapy, particularly when it's prescribed in that first 10 years after their last menstrual period, have a reduced risk of osteoporosis. That is known. That is fact. That is unarguable. We also know that women who are started on HRT in the first 10 years of their last menstrual period and don't get nothing over here, and then we're talking still about cohorts of women, generally have improved cardiovascular outcomes. We know that from a lot of observational data that predates the Women's Health Initiative. We also think, but don't know, because we have a lot more studying to do, that starting hormone replacement therapy in the 10-year window after the woman's last menstrual period helps with cognitive health and perhaps reduces the risk of dementia. We also know that estrogen, when started anytime, but certainly in the first 10 years after the last menstrual period, helps with the genitourinary syndrome of menopause, helps with sort of a sense of well-being, and helps with insomnia and the other sort of quality of life measures that are hard to quantify. Okay, so what does that mean? That means that what I've just said is that when you look at the Women's Health Initiative study that was halted inappropriately in 2002 and misinterpreted, it wasn't halted inappropriately. I should say it was misinterpreted in 2002 and there was a press conference that was held saying that there's a signal here in HRT that HRT causes breast cancer and is making women worse. So that press conference in 2002 was when the Women's Health Initiative studying these two arms of people, but in older women. I'm sorry. Okay, I'm confusing you. So the Women's Health Initiative was studying the difference between women who took HRT and who didn't take HRT, but they were older women. That study was halted in 2002 and scared the pants off a generation of women and, frankly, a generation of doctors who decided that HRT was too dangerous. When we go back and relook at that data, it is clear that that all-cause mortality was improved in women who took estrogen. It was clear that in women who took estrogen only, they didn't take progesterone, they took estrogen only, the risk of breast cancer was actually lower. So it looked like there was a protective effect of taking estrogen against breast cancer, believe it or not. And there was indeed a signal that there was an increase, more women, so 9 out of 10,000 women who took estrogen and progesterone, compared to 0 who did not take estrogen and progesterone, had breast cancer. So 9 in 10,000 women had breast cancer. So what am I trying to say? There was a signal that was real, that there's an association between the estrogen and progesterone taking women with breast cancer. But remember, the estrogen arm alone had a reduced risk. So we thought then that it was the progesterone, that it was maybe the progesterone to blame for the increased risk of breast cancer. Well, guess what? We don't prescribe that kind of progesterone now that we did back then in the Women's Health Initiative study. Moreover, the women studied in that trial were a lot older than women who are in that 10-year window since their last menstrual period. Okay, let's zoom out because I'm giving you a lot of information all at once. The point I'm trying to make is that the timing of the initiation of hormone replacement therapy matters when you're deciding who should be on HRT. If you have a woman who is in that 10-year window since her last menstrual period, and you look at that data showing that people tend to do better with HRT, you should start out with the assumption that that person should be on HRT unless there's a reason for her not to be. In other words, the burden of proof is on showing the woman or showing the doctor that she shouldn't be on HRT. It should be an automatic almost, unless there's a reason not to be on HRT, which includes patient preference, of course. Like, we don't force people to be on HRT if they don't want to be. My point is that for so long, for decades, we have defaulted to not putting a woman on HRT, to not having her on HRT, and putting the burden of proof on her or on a doctor who's afraid, in no small part because of the black box warning on estrogen products, to convince the doctor or the patient or whomever to be on HRT. So, for example, when I see a patient who's, let's say, 53, I'm just going to make this up, and she comes in to see me and she's at her annual checkup and she hasn't had her period in a year, she hasn't had it in 6 months, I say, unless there's a reason, let's put you on hormone replacement therapy. Well, why? Because in general, people do better. But let's talk about you in particular. Let's talk about what your actual risks and benefits are. And so now I'm going to take a moment to talk about what are the benefits of HRT and what are the risks. So I already kind of went over the benefits. The benefits of HRT are known to be on bone health. Definitely helps with bone density. And certainly the sooner you start taking it after menopause, the better for your bones. But it is not to say that taking it after the 10-year window has passed can't help you with your bone density. I'm going to say that again. If you are trying to protect your bones and you're outside the 10-year window, where like your last menstrual period was more than 10 years ago, it may still help with your bone density. It makes intuitive sense that it would, but it's not going to be the same as if you started it in the first 10 years of your last menstrual period. Okay. What else does hormone replacement therapy do? Again, it all depends on when you start it. The sooner you start it after going through menopause, the better you're going to do. It can help with cardiovascular risk reduction. So it can help with the reduction in risk of heart attack and stroke. Is it an inoculation against heart attack and stroke? Absolutely not. Are there exceptions? 100%. It can help with the genitourinary syndrome of menopause. So we're talking about not just vaginal dryness, but basically the thinning of the tissue of the vagina, the urethra, and all the pelvic organ sort of soft tissue that supports the bladder and the vagina. So over time and with gravity and when estrogen levels wane in a woman's bloodstream, those tissues get thin. They get dry, they get inflamed, and they can cause pain. That can cause pain with sex. It can cause urinary frequency. How many times do I see women in my practice who they think they have a UTI, and maybe they do, but sometimes they don't. They just have the sensation of bladder irritability, having to pee all the time, urgency, frequency, and they don't have a UTI. They just have they have a thirsty urethra. They have a urethra that is dry that needs more estrogen. So the genitourinary syndrome of menopause is real. And I'm going to get to the treatment of that in a minute. But my point is that we know that estrogen therapy helps with the genitourinary syndrome of menopause. Again, some women don't have that symptom, but a lot of women do. And if you ask enough questions, you realize people are suffering silently with painful sex, urinary frequency, sort of incontinence. And again, estrogen therapy isn't going to like magically erase all those symptoms, but it certainly can help because the number one driver of those symptoms is the absence of estrogen. So we know that hormone replacement therapy is important for bone density. It's not the only thing out there, but it's the hair of the dog that bit you. By giving you back estrogen, you're getting back, you're sort of watering your bones. Estrogen therapy can help with cardiovascular risk, particularly when it's started early. It can help with the genitourinary syndrome of menopause, as I just said. It can also help with, we think, preventing vascular dementia. This makes sense. I think we've talked about this before on the podcast. dementia is a complex disease, right? It's not one thing. There are the sort of neurodegenerative types of dementia and like Alzheimer's and frontotemporal dementia and, Parkinson's type dementia. And then there's the vascular dementia, the kind of dementia that stems from the absence of adequate blood flow to the brain over time. So to the extent that estrogen and hormone replacement therapy can help with vascular disease, like cardiovascular risk, it makes intuitive sense it would help reduce the risk of vascular dementia because it keeps your blood vessels happy. That said, we don't have enough data to say with any certainty that hormone replacement therapy prevents dementia or that hormone therapy prevents Alzheimer's. We may have that at some future date. In my opinion, and this isn't just opinion, there's got to be a reason why 2/3 of Alzheimer's patients are women. But again, we have lots of women patients out there walking around without being on HRT who don't have dementia and have perfectly sharp minds and who have no cognitive impairment whatsoever. So we cannot say with any certainty that hormone replacement therapy prevents dementia. But I would be a monkey's uncle. Is that like allowed to say anymore? That if it's not proven someday that there's a protective effect against vascular dementia and other kinds of dementia. But what we can say for sure is that hormone replacement therapy is good for your bones. It's generally good for your heart if you start it early enough. It's good for genitourinary syndrome of menopause. And then it's, of course, good for the quality of life metrics like sleep, sort of mood stability, which, count in terms of the assessment of one's health, right? Health isn't just about what your cholesterol looks like. It's about the quality of your sleep. It's about how you inhabit your body. And I, for one, can say that when I went on HRT, I'm in my early 50s, I didn't know that I had symptoms until I went on HRT. I didn't realize it was like, I didn't know that I didn't feel like myself until I went on HRT. Those are sort of immeasurable things, like just feeling like, the elevator's going all the way to the top of my brain are like, oh, okay, I actually have more focus and attention and I was sleeping better. So it's important to recognize how women have been suffering silently for a lot of years, thinking that HRT was unsafe, thinking that quality of life issues don't really matter, or if they do, it's not worth making a fuss about because my doctor's going to say no to hormone therapy anyway because there's this black box warning and I read on the news that it causes breast cancer. Well, the truth of the matter is that there's no known causal relationship between hormone replacement therapy and breast cancer. There is indeed an association between estrogen and progesterone therapy and breast cancer, but that is from the Women's Health Initiative study, and that is about the progesterone arm of that, or the women who took progesterone, and is about a progesterone we no longer prescribe. So nowadays, and particularly since yesterday, but for many of us well before yesterday, we have been trying to explain to women that it depends. It's not a yes, it's not a no on HRT. It depends. We now know, not just because of yesterday, but we've known for a long time that the average woman does better when she's on HRT when it started in the first 10 years after her menstrual cycle. We also know that there are exceptions to that rule. There are women who are 1 year postmenopause, who are, just going through menopause, who shouldn't be on hormone replacement therapy for a number of reasons. What are the absolute contraindications for being on hormone therapy? What are the reasons why you shouldn't take HRT? And what are the things that it can do over time in a negative way to a woman's health? Okay, so the number one reason why you shouldn't be on HRT, and I use the word should. It's not a moral statement. It's a most people wouldn't want to be on HRT because the risks are too high kind of should. Is if you have an active breast cancer that is sensitive to estrogen and progesterone. What do I mean? I mean, if you are someone who is actively in treatment for a breast cancer and the breast tumor itself has receptors for estrogen and progesterone, if I were to give you estrogen and progesterone, and if your own body is still making estrogen and progesterone, that tumor is going to be, quote, watered or fed by those hormones. Does it mean those hormones that your own body made or that a doctor could prescribe for you cause the breast cancer? No, it just means that is a reason not to be on hormone replacement therapy. I think many of you have not, I think, I know. Many of you have asked me about, what about my family history of breast cancer? Can I take hormone replacement therapy? The answer is, again, it depends. The most boring answer in the world, but it's an honest one. It depends on your family history. And it also depends on your tolerance for risk. But in general, of having a family history of breast cancer is not a contraindication to being on HRT at all. So again, going back to the risks of HRT, the number one contraindication, the reason not to be on HRT right this minute, is if you have an active breast cancer that is being watered by estrogen and progesterone, whether it's being made by your ovaries or you're being prescribed it and you're picking up estrogen and CVS. That's somebody who should not be on HRT. Another person who would think twice about being on HRT and a risk is the clotting risk. So I think many of you understand that estrogen is pro-thrombotic, meaning estrogen, whether it's made by your ovaries or you're taking it in the birth control pill or you're taking it in the form of hormone therapy, is pro-thrombotic. It can increase your risk for clotting. Important note though, the estrogen that is given by mouth, oral estrogen, is the most thrombotic, is the most likely to cause blood clots. Just because estrogen in an oral form is more likely to cause blood clots doesn't mean it will cause a blood clot. The whole expression, possible does not mean probable. But because no one wants to get a blood clot, and because we want to do anything we can to reduce the risk for blood clots, we have developed estrogen that is in the form of a patch or a gel that, just like oral estrogen, can give you estrogen into every cell of your body, but does not carry the same risk of blood clotting. In other words, we face risks when we take something like estrogen. We take risks when we do anything, whether it's taking Lipitor or it's driving in a car or taking any prescription medication or any vitamin for that matter. What we need to think about is not can I or can't I take this thing? It's what are the risks and how can I reduce that risk? What is the benefit and how can I get the most benefit? Okay, so the risk of HRT is number one, if you have an active breast cancer that is sensitive to hormones. Number two is if you have a clotting disorder like a protein C deficiency, a protein S deficiency, factor V Leiden. If you've had blood clots in your legs or your lungs before in the past, you want to be very careful about estrogen use. But taking estrogen transdermally through a gel or a patch significantly reduces the risk of clotting. In fact, those formulations of estrogen are designed for the very reason that they are supposed to offset the risk of clotting that estrogen can bring in its oral form. Estrogen can also cause endometrial cancer. Estrogen, if given without progesterone, that is estrogen, if you take estrogen by itself and you have a uterus, you can cause uterine cancer. That is arguably the only reason, in my opinion, why the black box warning should ever have existed on estrogen products. Because believe it or not, there's some doctors out there who don't know that if you give a woman estrogen postmenopause and she has a uterus and you don't give her progesterone, she can develop uterine cancer. So that problem is easily solved. You take estrogen and progesterone together. The estrogen helps you with the bone density we talked about, the genitourinary syndrome of menopause. It helps with the quality of life metrics, like sort of cognitive health. May help prevent dementia. We don't know yet. Definitely can help with cardiovascular risk reduction if you start it early. But you have to be on progesterone as well if you have a uterus. Why? Because progesterone helps keep the uterine lining thin. So, again, if you're in that 10-year window since your last menstrual cycle and you're wondering, should I be on HRT or should I not? You should first think about the reasons you shouldn't be on it. Because most women, like I said from the very get-go of this podcast, most women do better when they take HRT started within that 10-year window. So think about why you shouldn't be on it. If you're wondering if the family history really matters to you, think about it this way. And again, personal preference is huge, right? Like my job isn't to sort of shove hormone replacement therapy down people's throats. It's not to be ideological or have the same tolerance for risk that I do. It's rather to say, look, there are risks of being on estrogen, there are risks of not being on estrogen. So let's balance those two things out and understand how you can reduce your risk on this side and reduce your risk on this side. One way to reduce your risk of estrogen is not to take it at all. But then you're increasing your risk for osteoporosis and you may be increasing your cardiovascular risk. So again, as a doctor, my job isn't to stomp out every risk. We cannot make risk zero. You cannot make risk zero. You're here to help people understand the facts and then to mitigate risk and to help them make decisions based on what they prioritize. So, for example, a woman who has a family history of breast cancer, let's say her grandmother had breast cancer, her mom had breast cancer, and she's worried about, wow, if I take hormone therapy, I might get breast cancer. Well, I would say to that woman, let's say you were my patient, I would say to her, okay, first of all, and hear me out. This is not to minimize the impact of breast cancer. Breast cancer is a beast. Although in 2025, it's much easier to treat if it's caught earlier than it was, say, 10 years ago, even. 1 in 8 women will get breast cancer. So 1 in 8 women will get breast cancer. The average lifetime risk for a woman is 20, it's like 15%, something like that. So having breast cancer in your family doesn't mean it's like a hereditable disease. It may just mean that you have women in your family. In other words, statistically, if you have enough women in your family and you talk about cancer, you're probably going to come up with someone in your family who's had breast cancer because it's common. In fact, if we all lived long enough, we might all get breast cancer because it's an age-related phenomenon. The vast majority of breast cancer is age-related, not hormone-induced. Okay, so if you're worried about being on HRT because you have a family history of breast cancer, like, you're welcome to worry. You have every right to be concerned. I mean, I have patients who witness their loved ones go through the horrors of breast cancer treatment, and they're like, I don't care if the risk is like 1 in a million with HRT. I'm not taking that stuff because I don't even want to tolerate that single risk. That is their choice. But what I don't want women to do is toss out the notion of being on HRT because of a family history when perhaps that family history exists because statistically 1 in 8 women get breast cancer regardless, and because HRT didn't have anything to do with their breast cancer evolution, and because we don't think HRT causes breast cancer anyway, and finally, because we can screen for breast cancer nowadays with mammogram, sonogram, breast MRI when appropriate, and more importantly of all, in my mind, is that women are more than just a set of breasts. Like, if we see everything, let me say this again. Women are more than a set of breasts. If we see a woman's health simply through the lens of preventing breast cancer, we run the risk of not giving her hormone therapy to then help her bones, her brain, her heart, her genitourinary health, her sexual health. If we see women as a set of breasts and doctors are afraid of giving hormone therapy because of outdated recommendations that were born out of fear from 20 years ago, we're really doing women a disservice. So I said I wasn't going to make this a public service announcement, and it really is not a call to action for every woman to be on HRT. It's not. What I'm asking you to do is to understand that risk is everywhere, that there are risks of taking hormone therapy, absolutely. But there are risks of not taking hormone therapy too. And my job and your doctor's job isn't to say you can, you can't, yes, no, do as I say. It's to say, here are the risks based on evidence. Here are the benefits based on what we know about you. And then have you make a decision with the doctor in a partnership, knowing that the future is not known to anybody. So, for example, when I opened this little ditty by talking about a theoretical person, although I don't need to make it theoretical, I see women like this all the time, but the woman who is worried about being on HRT because she has the family history of breast cancer, naturally, so she doesn't take HRT. Well, what about her bones when she's 80? What about going to the ER for frequent urinary tract infections when she's 85? What about the urosepsis she develops because as we age, we don't always feel the fact that we have a UTI and she goes into the hospital and develops sepsis? What about the hip fracture from the osteoporosis paired with the urinary tract infection and the ICU admission for that? that's what a lot of my older patients are dealing with. And estrogen, as I put in my sort of sassy headline this morning, may not unite the country politically, but it's really a undervalued resource when it comes to helping women with morbidity and mortality. And I think the punchline here is that it's overdue for the FDA to have pulled the black box warning off of vaginal estrogen for sure, because that's just topical estrogen. That is just like chapstick for your genitalia. Oh my gosh, did I just say that out loud? I did. So vaginal estrogen should not have a black box warning on it. It never should have, because it is a topical treatment. It is topical to the urethra, to the vagina, to the genitourinary soft tissues to help with pain with sex, to help with comfort, UTI prevention, pelvic floor strength, continence, etc. So that should never have had a black box warning. I think I heard someone, maybe it's Rachel Rubin, who's a dear friend, say that it's over the counter in the UK. I think it's over the counter in the UK. Regardless, it should never have had a black box warning because it's topical. It's not even absorbed in amounts through your bloodstream that would affect you in any negative way. Systemic estrogen, that is hormone therapy that reaches every cell in your body when you take it by mouth or you take it by a patch, I think should maybe have a black box warning because of the estrogen causing uterine cancer if you don't give someone progesterone with it. And some doctors, believe it or not, don't know that if you give someone estrogen and not progesterone, they can get uterine cancer. But I think that the black box warning should come off of HRT in general, because there are things that we prescribe every day that are much riskier that don't have black box warnings. I think it boils down to we all need to have a doctor who understands the data and understands you. And so as a proxy for that, we just put black box warnings on women's health products and just call it a day. Sideline issue, separate issue, huge issue. I'm not going to cover that today because my head would start spinning. But what I'm saying is that the answer to the question, should you be on HRT? I can't answer. Neither can the FDA. Neither can anybody on social media or any medical messenger, because the answer is the boring, it depends. The answer actually is not you can or you can't. And the question isn't, let's reframe the question from the beginning. The question shouldn't be, can I be on HRT, or can I, is it safe for me to take HRT? Those are actually not the questions you want to be asking. You want to be asking this to your doctor and to yourself. What are the benefits of HRT for me, given how old I am, given my symptoms, given my other health conditions? And what are the risks to me, given the evidence, given my health conditions, and given my tolerance for risk? That's the question you want to be asking. And if anybody says to you that you should be on HRT, who's a medical messenger in the public square, and I'm certain of it, or you should not be on it because of this XYZ, because of your breast cancer history, I wouldn't believe them at all, because it depends. It depends. If I wrote a book called It Depends, it would not sell. It would be in the basement of the most boring bookstore of all times. But that's the truth. It depends. But again, the headline here is that estrogen products should no longer have black box warnings. What that means is, actually, Debbie Weil, if you're on here, you asked me a great question on my Substack today. Debbie asked me, so what does that mean with the black box warning coming on? Does it coming off the warning labels? Does that mean that doctors are going to start prescribing more hormone replacement therapy? And I said to her, I don't know. It hasn't happened yet. But to the extent that doctors hid behind the black box warning and didn't prescribe HRT, saying it's dangerous, or were too afraid to prescribe it even though they knew the data, or to the extent that the black box warning signaled to doctors that it was unsafe, and doctors don't have time to read up on everything. I had to educate myself on hormone therapy. I did not learn any of this in medical school. I learned some of it, but you really have to educate yourself. That's part of being a doctor, right? Is like the iterative nature of science and keeping up with medical data. My point is that I don't know if more doctors will prescribe HRT when the black box warnings come off of the products. But I do know that the existence of the black box warnings has prevented generations of women and millions of women in the United States from getting the kind of treatment they need for their various symptoms of menopause at the moment and the risks long term of not having estrogen and progesterone. So I don't know, but I think the label is just a label. What we really need is more than just the label coming off. We need medical schools to start educating doctors about menopause, something that happens to 50% of the population if they live into their middle age. We need medical schools to help young doctors understand the data on HRT. It's not it's just the data. And doctors need to understand whether it is when we're thinking about HRT or we're thinking about any medical intervention, that the decision to prescribe or not to prescribe, to take estrogen or not to take estrogen, isn't a binary, isn't a yes, no. It's a what's the data and what's going on with my patient? What are the benefits to this patient? What are the risks of this patient? And what does the data show? So I think the answer to your question, Debbie Weil, is I wish that the label coming off was going to suddenly, allow, people to get what they need. But I think it's more complicated than that. I think you have to take the label off and then you have to arm doctors with the data and the understanding that risk is everywhere. And there are risks of being on hormone therapy and there are risks of not being on hormone therapy. And that's the inherent tension there. It's not a yes or no, can I, can I? I'm going to speak directly to the person who asked me. Actually, a number of people have asked me over time, but a couple people today asked me. They have the BRCA gene, the BRCA gene. So someone, I can't remember your name, but you asked me this morning that you have the BRCA2 gene, the BRCA2 gene. That's the breast cancer gene. What does that mean? When you have the breast cancer gene, the BRCA1 or BRCA2 gene, that means your risk of breast cancer is significantly higher than the average woman. As I said earlier, the average risk for the average woman in the US is 1 in 8 in your lifetime of getting breast cancer. Having the BRCA gene significantly increases that risk. It's not an inevitability, and most breast cancers, like I said earlier, are not hereditable. They're just sporadic. They just happen. But if you have the BRCA gene, it doesn't mean you're inevitably going to get breast cancer, but it means your risk is significantly higher. So can you be an HRT if you have the BRCA gene? So I'm going to go back to my mantra here. It depends. Risk is not a monolith, right? Risk is on a continuum. So let's say you have the BRCA gene and you have done your due diligence, you've met with a breast specialist, you've talked to your internal medicine doctor, you've talked to your gynecologist, and let's say you're postmenopausal and you don't have estrogen in your body anymore, and you've gone ahead and you've had your breasts removed. You've had a prophylactic mastectomy. So that is the option some women take when they have the BRCA gene. Because of the increased risk of breast cancer and ovarian cancer for BRCA1 and 2, some women will undertake surgeries to prevent getting breast cancer, prevent getting ovarian cancer. They will have their breasts removed and their ovaries removed. Those are major, major, major life decisions. They are major medical decisions, but they are the decisions that many women make when they have that increased risk, especially if they've seen their family members go through cancer treatment, or if they've had people in their family die young from breast or ovarian cancer. What's the alternative to having radical surgery when you have a BRCA gene is to have aggressive surveillance for these cancers. So more frequent imaging of your breasts, more frequent imaging of your ovaries. Okay. My point here is that people are asking me, and people should be asking me and many other doctors out there, is it okay to take hormone therapy when you have the BRCA gene? What I'm trying to say is the risk is not a monolith. If you undertook the effort and medical risk of having your breasts removed and your ovaries removed because you have the BRCA gene, remember the reason you did that. The reason you did that is because you are trying to reduce your risk for breast cancer from a high risk to like near zero, right? When you have a total mastectomy, you take away all your breast tissue. So I have a couple of patients who are BRCA2 positive who are on hormone replacement therapy. Why? Because they don't have breast tissue, theoretically, right? So when you don't have breast tissue, you can't get breast cancer. I want to be clear. I am not recommending to you listening that if you had BRCA and you had a mastectomy to be on HRT. I'm saying that risk is not a monolith. I am saying that if you had your breasts removed, completely removed to reduce your risk of breast cancer, of course you can take HRT. You could have taken HRT even if you had breast tissue and had BRCA. It's your decision, not mine. What you need to understand about BRCA is that it does increase your risk for breast cancer. And there's an association, as I said earlier, 9 in 10,000 women, if you take estrogen and progesterone together, of breast cancer. But the risk you want to undertake to be on HRT, to benefit from it, bones, brain, heart, is up to you. I have a number of patients. I think I have 3 patients who are BRCA 1 or 2 positive. One had breast cancer, so that's a more complicated decision, but she still decided to take HRT. And 2 have not had breast cancer. They did the mastectomy prophylactically. So presumably they have no breast tissue. And presumably even my patient who had breast cancer, we think it didn't spread. She has no breast tissue. So they're all happily on HRT because guess what? They're almost at lower risk than the average person of getting breast cancer because they don't have breasts in the first place. So what I'm trying to say to you is I'm not trying to be confusing, and I know I'm talking really fast, but what I'm trying to say to you is risk is relative. If you have the BRCA gene and you've had a mastectomy, your risk of getting breast cancer went from being real high because of the gene to being near zero because you don't have breasts anymore. If you have a family history of breast cancer, that could just be that you have women in your family because 1 in 8 women get breast cancer. And again, as I said earlier, I don't like to look at a woman's health in the totality of her life as a set of breasts and a potential risk for breast cancer. I like to look at breast cancer as one of the myriad things that she might face in her life. She might have osteoporosis, she might have a fracture, she might have painful sex, she might have mood instability, she might have vascular problems. So our goal is to help women live their best, longest lives and to mitigate the risks of cancer, cardiovascular disease, cognitive health decline, fractures, poor quality of life, and optimize those things when we can without adding undue risk. And most importantly, by empowering the patient herself with the understanding that risk is everywhere and you can't mop it up. You can't make it zero. There's a risk of taking estrogen. There's a risk of not taking estrogen. Okay, so what other questions did people ask? I'm sure that you're writing questions in right now, and I'm not answering them because I'm just going on and on and on. But I'm going to look at the questions that you guys have written in today. Oh, this is someone else. Laura wrote me today. I was refused HRT. I think what you mean, Laura, is that someone refused to prescribe HRT for you 20 years ago because you had DCIS and you're BRCA positive and you're 67. And she wrote me and she said, I want to see if HRT would help tighten my tongue and palate because she has sleep apnea and help build bone and muscle strength as I improve my exercise routine. Okay, so if you're 67, you are outside the window, the golden window of opportunity to start HRT. As we talked about from the beginning, you can take HRT outside the 10-year window. Just because the data show that most women, the benefit is greatest if you start it in that 10-year window, doesn't mean you can't take it outside the 10-year window. I'm going to say this again. I'm not saying everyone should be on HRT regardless of when your last period was, or that I'm just saying that there are no absolutes here, right? What is absolute is that you should absolutely have a conversation with your doctor about the data and how it applies to you. So just because it's true that women tend to do better when they start estrogen in the first 10 years after their last period doesn't mean you can't start it when you're 11 years postmenopause, when you're 12 years postmenopause. But I will say you may not get as much of a benefit because you didn't start it young. So when you haven't had estrogen in your body for 10 years, 20 years, or in Laura's case, maybe for 20 years, you haven't had estrogen in your body, your estrogen receptors in your body have been down-regulated. Your body becomes less thirsty, so to speak, for estrogen, meaning like you may not get the benefit of estrogen like you would have if you had taken it in the first 10 years of your last period. But that doesn't mean you can't take it. I would say to Laura, who's asking me if HRT would help with like tightening up tissues, I cannot tell you it's going to tighten up your like oropharyngeal musculature, and I frankly don't think it would. What estrogen can do is if you take it topically, vaginally, it can help tighten up lax tissues in your pelvic floor because that's where estrogen was before, and it was directed to those tissues. It's not a panacea for all, like, lax tissue, unfortunately. And certainly if you haven't had estrogen in your body for 20 years, there's not a whole lot that estrogen is gonna do. You probably have seen these ads for estrogen face cream. There's no data to show that estrogen face cream is gonna help with, like, wrinkles and, sunspots and, like, make you look like you're, Chrissy Turlington or something, although she looks great, and she's got a lot of wrinkles, and I love that. She's very untouched. But my point is that I don't think it can hurt you. Putting estrogen on your face is probably like putting estrogen on your vagina. It may help here, but we know it helps with vaginal dryness. We know that that is tissue. The genitourinary tissue is the tissue that wants to have estrogen, and without it, it gets dry and could cause pain with sex and UTIs and all the things we talked about in the first half of this conversation. But to Laura, who's asking me about the fact that you have the BRCA gene, which predisposes you to breast cancer, and you have sleep apnea and you want to build bone and muscle strength, I would say to you that it's not off limits to be on hormone replacement therapy because of the BRCA gene. That's just up to your risk tolerance. And if you are BRCA positive and had your breasts removed, your risk for breast cancer is probably low anyway. Um, and then I would say talk to your doctor because risk is everywhere, like we've been talking about this whole time. What about starting HRT vaginally post 10-year window? So that to me is a no-brainer. Vaginal estrogen to me is like putting on like chapstick to dry lips. So the 10-year window thing applies more to the systemic estrogen. We're talking about the delivery of estrogen to all of the cells in your body through a patch or through a tablet or through a ring or a gel. Vaginal estrogen, just topical estrogen, which is not even absorbed into your bloodstream and if at all, um, is really, really high return on investment for women at any age to help, prevent the genitourinary syndrome of menopause. Just like anything, though, you're going to get more benefit if you started earlier because if you started 20 years after menopause, you've had time, your body has had 20 years to be dry vaginally, to have atrophy of the tissue, and perhaps to not have the muscle tone and strength that you need to have full continence. I'm not saying all is lost. I'm just saying that just because you're after the 10-year window doesn't mean you can't take estrogen systemically. And certainly it's okay to take vaginal estrogen, just have managed expectations for what it can and cannot do. But for my older patients who were unfortunately who went through menopause during the era when they were told they couldn't take it, I prescribe vaginal estrogen all the time, even to people who've had breast cancer, because vaginal estrogen, topical estrogen, is not absorbed systemically. And by the way, even if it was, it's still potentially okay to take systemic estrogen. But vaginal estrogen is something I recommend almost every day. Like my patients are almost all taking it because they've been my patient for long enough. And if they're not, they're either getting more UTIs or they're having pain with sex or they're not interested in sex. So I think that is something of a no-brainer, but I still don't want to be prescribing medical advice to everyone here and sound like it's a no-brainer just because I said so. Talk to your doctor, and I think there's got to be a good reason not to be on vaginal estrogen. I had one patient who was allergic to the darn carrier material in vaginal estrogen. That was so unfortunate because you can't really be allergic to a naturally occurring hormone, but she was allergic to the carrier, like the stuff in the cream. So we tried a different formulation. I just put her on it last week, and we'll pray that it works. So Claire is asking, topical estrogen is not absorbed systemically as long as it's used in tiny amount allowed. They've been very strict with it about me. Well, so Claire, I think so. So that's a great question. So the topical estrogen is typically prescribed in the form of a cream or a tablet. And the typical way we prescribe it is we say take it every day for 2 weeks. So if you take the cream, you just put like a little bit of cream, like the top little part of your finger right here. And instead of just like throwing it onto your groin and then running away, you want to actually rub it into your tissue. Like actually rub it in like you'd rub in sunscreen, right? You want to just get it in there into the tissue so it's absorbed. So just like there's been hyper caution and in my opinion a lot of fear around estrogen in general, there's been a lot of hyper caution about vaginal estrogen and prescribing it too much. So the rule on the prescription is that it should be every day for 2 weeks and then taper to twice a week for maintenance. So twice a week is the maintenance dose. That doesn't mean you can only take it twice a week. You can take it 3 times a week. If you're still dry, if you're still having UTIs, if you still need more estrogen for, comfort with sex or to prevent landing in the hospital with a urinary tract infection, you can take it 3 days a week. Just because the cookbook says 2 times a week doesn't mean you can't take it 3 times a week. In other words, what I'm talking about is understanding the whole purpose of being on these hormones to begin with. The purpose isn't to adhere to the strict guidelines from the prescription bottle, it's to treat your needs and to understand the risks at the same time. It is true that when you take estrogen vaginally 3 times a week, or 4 times a week, or 5 days a week, you are going to run the risk of having a little bit of estrogen absorbed into your bloodstream. The question is, are you okay with that? It's the title of my newsletter. Are you okay with that? And the answer is maybe you are. Because remember, even if you took systemic estrogen, which is the kind of estrogen you take by mouth or by gel or by patch, you may want that also. You may want to be on estrogen systemically, even if you're 10 years out from menopause, because of the potential benefits on your bones. Again, if you start HRT after you've been 10 years postmenopause, like in your 60s or 70s, the benefits are going to be less than if you started it early. But it doesn't mean the benefits are zero. So going back to the woman who said, I am only being prescribed it twice a week and I'm worried, or my doctor's worried it's going to get absorbed into my bloodstream if I take it more. Well, this is the reason we took the black box warning, or we're going to take the black box warning off of vaginal estrogen for sure, and then systemic estrogen too, because the risk of topical estrogen is so low, and the risk of something that's really low taking a little bit more is also still low. And even if it's absorbed systemically, we need to be honest about what the actual risk is for having a teeny tiny amount of estrogen circulating in your bloodstream. Is it on breast cancer? Well, the data showed that it was the old progesterone that may have been the problem. We don't even prescribe that anymore. And there are actual benefits of estrogen, even if you start it later in your life, but the risks are not zero. So back to my book that's never going to, not the book I'm writing, but the book that I will never write because it would never sell and because it would be just only doctors would read it. The book that I would like to write, but it would never sell, is called It Depends, because that is the refrain here. It depends. Again, I want to give you the headline, the punchline here is the question you should be asking your doctor isn't this. It is not, can I be on hormone replacement therapy? Should I be on hormone replacement therapy? Can I take hormones when my grandmother had breast cancer? Those are not the questions you want to be asking. The question you want to be asking is, what are the unique risks of topical or systemic estrogen hormone therapy for me? And what are the unique benefits of topical or systemic estrogen for me? That's it. Bam. That's the question. What are the unique benefits and what are the unique risks? Because it's not a no, it's never a no. You can, I think that doctors need to be like licensed and have gone to medical school. And to that extent, we need to be, dispensers of advice and guidance. I'm not going to have my patients just tell me what they want. And I'm not like the Cheesecake Factory where they can just, choose what they want. I'm not like In-N-Out Burger. Like I'll have a side of estrogen and a little dab of testosterone. No, we need to be the prescribers and the advice givers. But what I'm saying is we should not be in the position as medical practitioners, and certainly we should not be in the business of saying, you can't do that, you shouldn't do that. No. We should be in the business of arming you with information and data and helping you frame a decision to best honor your health situation, your health concerns, your health problems. Like I would never tell a woman who had a fear about breast cancer, understandably, who was having terrible genitourinary symptoms of menopause and had a high risk for osteoporosis and UTI risk to not take estrogen because of her breast cancer risk. I would understand her fear of breast cancer, and I wouldn't push her either way. I would just say, wow, let's acknowledge that the fear is real, but let's not yet let fear make the decision. Let's let the evidence make the decision, and let's help you with the issues that you have and understand that risk is everywhere. Risk is not something we could mop up to zero like your spilled milk on your kitchen counter. And it's all relative and it's not monolithic. Everybody's risk is different. So I hope that's helpful. I mean, I've been talking a long time. I've been talking straight for an hour and I'm not even tired. I think it's because I feel very passionately about this subject matter and I feel so badly for women who have been deprived for generations of information about their own bodies. I really do. I mean, I feel like the luckiest person in the planet that I'm going through menopause or I've been through menopause in this era. I just feel really badly for people who have been told, nope, it's been 10 years, you can't take hormones. Nope, you have breast cancer in your family, you can't take hormones. Nope, there's a black box warning on the estrogen, can't take it. Nope, I don't have time to talk to you about it. Nope, hot flashes don't matter, night sweats don't matter, sex is a luxury. I don't know if anybody ever said sex is a luxury, but that's the messaging, even if no one said that out loud. We need to be advocates for ourselves, and men need to be advocates for women as well. I wrote a long piece last week about testosterone. Testosterone is not a menopausal related phenomenon. It's age related. Testosterone can be great for libido. It can be great for maintaining muscle mass, but the data aren't there on the long-term safety. But it's hard to imagine that the long-term safety data, if we ever get it, will show that it's dangerous when it's a naturally occurring hormone. In fact, women make more testosterone than we do estrogen. Go figure. So, let's see. Any other final questions? I was on tamoxifen 2 years and letrozole for 7 years. Brutal. Claire, I feel you. That is brutal treatment. That is intense. Those treatments for breast cancer or for, I'm assuming you had breast cancer with the BRCA gene, they're brutal. And they're trying to help your body mop up all the last bits of estrogen, whether the estrogen was made by your ovaries or whether it was made by, a pharmaceutical company and prescribed, so that you are not stimulating your breast tissue. Can you be on HRT after you've been through tamoxifen and letrozole? You can. The risks of recurrent breast cancer, if you have breast tissue, is still going to be higher than if you hadn't had breast cancer. But the benefits of HRT are not zero. So I hope that's helpful. And I hope you understand my absolute compassion for women with breast cancer, women who have a high risk for breast cancer. You are my patients. I see you. I just feel a moral imperative. It's truly kind of a moral imperative not to see women solely as breast cancer risk. Even women who've had breast cancer. My patients have every right when they've had breast cancer to think about their health only through the lens of their breast cancer, but they can still have a heart attack. They can still get a bone fracture. They can still get dementia. So if we're truly honoring the whole person, we want to think broadly about how to improve quality of life and morbidity and mortality for every disease out there when possible, and do no harm at first and foremost. But doing harm includes not educating women about facts and information about their own bodies. So I hope that's helpful. Thank you so much for joining me. I have been talking so long. I think I'm going to go home and lie down on the couch and probably scroll through some brainless cat videos on Instagram or something, because I'm all fired up about hormone replacement therapy. And I really appreciate you joining me. And please write more questions and please send this. This is my request to you. Please send this video to your friends or send it around, because my goal isn't, I'm not trying to make any money off this. This is all free. I just want to spread information. And I also would love your feedback. Tell me if I'm talking too fast, if it's too much information at once. Please share this widely, because there's so many women out there who are afraid of HRT. There are so many doctors out there who are afraid of HRT. And I just want, if there's one person out there who then takes this conversation to their doctor and asks their doctor the right question, which is, what are the risks and what are the benefits? Not can't or can't I? That is a small victory. Thank you guys for joining me. I will see you next week. Have a nice night.